Speaking of triglycerides, the REDUCE-IT trial really helped put triglycerides back on the map again in a way that they haven't been in probably at least a decade or maybe a couple of decades. And REDUCE-IT, just to recap, was a study, a randomized clinical trial of over 8,000 patients, randomly assigned to icosapent ethyl or placebo, and followed for a median of 4.9 years, a maximum of 6.2 years, and cardiovascular events were assessed. So icosapent ethyl, first of all, is EPA, or icosapentaenoic acid, a highly purified ethyl ester of icosapentaenoic acid, one of the omega-3 fatty acids, and it's a prescription medication, not to be confused with supplements that a patient or person could just buy in a store. This is a highly purified distilled ethyl ester that was studied in REDUCE-IT, but also had been studied in a couple of other triglyceride-lowering trials, found to be safe, found to be effective, and in fact approved for severe hypertriglyceridemia by the FDA a number of years ago, with the goal of hopefully preventing pancreatitis, which of course is a concern when the triglycerides are 500 milligrams per deciliter or greater. But in REDUCE-IT, we studied patients with triglyceride levels that were above ideal, above 135 milligrams per deciliter was the inclusion criteria, but below that 500. So in patients with that range of triglycerides, with LDL that was well controlled on a statin, we required statins in the trial, and LDL that was even by current standards well controlled, there we randomized the patients to icosapent ethyl or placebo. And the dose of icosapent ethyl was 4 grams a day total dose, or in fact 2 grams twice a day with meals. And the additional risk that patients had to have, in addition to the triglycerides being not normal, were either established cardiovascular disease, which really meant atherosclerosis anywhere in the body, or diabetes plus additional cardiovascular risk factors. So you could say high risk primary prevention. So pretty much the full universe of secondary prevention and high risk primary prevention. The overall trial was very positive, showing a 25% relative risk reduction in first ischemic events, including a 26% reduction that was highly statistically significant in the endpoint of cardiovascular death, MI, or stroke, and including a significant 20% relative risk reduction in death from cardiovascular causes. So very positive trial. A number of different subgroup analyses and secondary analyses have been presented to date, showing large reductions, for example, in revascularization, significant reductions in coronary artery bypass grafting as an endpoint, really potent effects in patients with diabetes, either in the secondary or primary prevention cohorts from REDUCE-IT. Really a consistency of benefit across multiple pre-specified subgroups. So overall, a very robust trial with large relative risk reductions, also large absolute risk reductions in time to first event. And when we examined recurrent events, so first events and recurrent events equaling total events, there are very large reductions, a 32% relative reduction in total ischemic events in this population of patients. The total number of ischemic events reduced from about 1,700 to 1,100 or so, so about 500 less events in this population. So a very, very large absolute risk reduction as well. And of course, I'm speaking here to the editors of medical economics. I've got to mention what the ramifications might be in terms of economics of those sorts of findings. Obviously, the main reason to try to prevent events is for the patient to increase lifespan, to increase quality of life, to decrease ischemic events in the context of cardiovascular drugs. But beyond that, you might imagine then when we're preventing so many events, not just first events, but recurrent events, what in medical jargon we sometimes call the frequent flyer that keeps coming in with repeated ischemic events. Well, obviously from a healthcare systems perspective, there are enormous financial costs associated with that. So if we can reduce first events, that's terrific. And if we can reduce recurrent events, that's icing on the economic cake, so to speak. So really, in addition to the clinical benefits, economic ramifications to the healthcare system from the findings of REDUCE-IT.